All right, welcome back. This one will be a little bit different in that I'm going to guide you through a PowerPoint just because it has a bit more images this way than I could fit in a note packet, but it actually coincides with the note packet pretty much word for word. I'll try to emphasize and highlight those areas to make sure you know when to fill things in, and I'm also going to make this PowerPoint available to you. So what are we covering now? The last little bit of the endocrine system is we're looking at, hormone interactions briefly. And then we're going to look at the majority of this lecture will be actually on endocrine disorders. So we've seen how these hormones are supposed to work. Now we're going to look at, okay, what happens when things go wrong. But first, again, let's start with the concept of hormone interactions. So, first and foremost, we know that hormones are going to be ways of intercellular communication. It only makes sense that to have an integrated system trying to, again, getting 30 to 40 trillion cells to work in a systematic integrated fashion, well, you're going to have hormones that are sometimes going to help each other along and other times they're going to contradict each other. We've already seen a few examples of that. So what do I mean by this? Well, let's give some terms first. First, we could have cells that are actually receiving information from hormones that actually have antagonistic effects, which means the two hormones are actually opposing each other as far as basically telling what that target cell what to do. Then we have additive or synergistic effects where it just compounds the effects. And other times, it's not just that they're both adding to each other as far as the ultimate outcome. Sometimes you have permissive effects, meaning you have to have one hormone first in order to have the effect of the second. And then finally we have integrative effects, which means they produce different effects, but they're working together complementarily. All right, so hopefully those words are pretty self-explanatory there. So again, I meant to give this to you here. So we have, as far as the words to fill in on your note packet, that's pretty self-explanatory, I think, but there's the little highlights for you. All right, now we're going to talk about specifically hormones that are important for growth. So those, again, hormones that might be synergistic or integrative, they're going to help the body grow. Well, most obviously we have growth hormone. Okay, we'll talk about that one first. It's actually kind of in the name. We talked about growth hormone and actually insulin-like growth factor. I'm going to put IGF-1. Both work very much both synergistically, and technically you need growth hormone first in order to get IGF-1 from the liver. Very much going to target virtually every cell in the body. Then we have thyroid hormones. We already talked briefly about how that's going to be really important for growth of the body, especially in the nervous system early on. We're talking about insulin, parathyroid hormone, and calcitriol, and the reproductive hormones. And again, knowing these hormones already, you should already have a pretty good idea. So growth hormone in children, the main thing is it's going to be muscular and skeletal development. But in addition to that, it's going to help maintain normal blood glucose concentration. So it's going to work with other variables, other hormones, I should say, such as insulin and glucagon. And we'll find out also epinephrine and other things, all that are going to help regulate blood glucose, again, very, very tightly. And it's also going to mobilize lipid reserves. Now, pause for a minute and think. If we are talking about growth, that means we are going to need the raw materials and fuel for that growth. And that's what we want to be concerned about here. And that's why it makes sense that growth hormone is actually involved in regulating blood glucose levels. All right, what about thyroid? We already mentioned, if you recall, if it's absent during fetal development or for the first year, you have major nervous system retardation. All right, so it's not going to develop normally. So that's really important for early nervous system development. Now, If T4 concentrations decline before puberty, and remember, we make a lot of T4 and it has to be converted to the active form of T3, but T4 is what we have a lot regulating in the blood. If we don't have enough T4 regulating, if we don't have enough T4 in the blood, we actually don't have normal skeletal development either. So lots of problems if we don't have proper thyroid hormones. Insulin, well, you already know that that's going to allow passage of glucose and amino acids, for that matter, across plasma membrane. So it's essential for getting the fuel inside the cells. That's going to, again, react with growth hormone, epinephrine. It's going to be antagonistic to glucagon. Once again, start putting the pieces together. Parathyroid hormone and calcitriol, well, what's going to happen there? We know that these are the ones that are going to help regulate blood calcium levels, right? It's all about blood calcium levels. We talked about that. And if we don't have proper levels of PTH and calcitriol, well, then we can have weak and flexible bones. And as far as the reproductive hormones, of course, we already know we have androgens in males and estrogens in females. What are they going to do? They're going to stimulate cell growth and differentiation, and specifically, they're going to produce the gender-related differences, such as skeletal proportions. Men tend to be both larger, women tend to have a wider pelvis, as well as all the secondary sex characteristics. Women developing breasts, men developing facial hair, a thicker, deeper voice, and so forth. What about hormones and behavior? You probably are fully aware of this already, but hormone changes can actually affect your intellectual capabilities, memory, learning, and emotional states. And I know those aren't all blanks, but they probably should be on your note packet. Just like the nervous system is so important for communication and pretty much regulating these things, well, we know that the endocrine system is the other major form of intercellular communication. No big shock that the endocrine system can affect the nervous system. One thing that I don't like to tell my kids when they're being what I'm going to say overly emotional, I'll say sometimes they're being hormotional since they're in puberty, but that's a bad joke. Anyways, and the thing is that hormones can affect behavior when either you have over-secretion or under-secretion. So again, there's homeostasis that we're concerned. If we don't have proper homeostasis of certain hormones, they can, in fact, affect behavior. What about hormone production and aging? Well, there's definitely, as with everything, when you age, things start to decline. So the two big ones, as far as the endocrine system, not the only two, are declines in growth hormone and reproductive hormones. Those are the main ones that are going to cause some changes. So that was kind of quick, talking about just kind of still revisiting some of the stuff we've already talked about. What I really want to talk about is this right here, which is what happens when something goes wrong. That means we have hypo or hyper secretion of a particular hormone. So of course, hypo meaning too little or low, and this is high. Hyper is high. You know that already, but might as well state the obvious there. So there's a table in your notes. This is kind of another version of it right here. That's going to actually go over over versus under production of some of the big hormones that we've talked about so far. And remember, I've already said this, I'm only giving you what I might call the big ticket items for hormones. There's a lot more hormones in this. So, what are we doing here? We're going to talk first about growth hormone. We're going to talk about what happens if you have too little hyposecretion versus hyper, too much. And I'm betting you can probably already guess what the result might be. So what do we know already about growth hormone? Well, we know it's a peptide hormone secreted from the anterior pituitary. We know it affects all the cells in the body, and we know that it's controlled by the hypothalamus, by both growth hormone releasing hormone and growth hormone inhibiting hormone. So let's talk about what if we have hypersecretion? Well, that would imply someone's getting more growth, right? That's exactly what happens. And there's two disorders here. We have gigantism and acromegalia. And the biggest difference between gigantism and acromegalia is basically with gigantism, the excess growth hormone happens before puberty is done and before the epiphyseal plates are sealed. So that usually happens around age 18, which means these people grow abnormally tall. And they tend to have a little bit of disproportionate features like hands and feet. Acromegalia, you have excess of growth hormone, but it's after puberty's done, after we've already have the epiphyseal plate. So it's not like you're going to get that much taller, but in a sense, everything gets thicker. In fact, acromegalia means enlarged extremities, and specifically like the hands and face tend to get broader and thicker. So here's a case of a couple pictures with gigantism and cases of acromegalia. Now, Andre the Giant, who's on the left, if you don't know who that is on the screen, he was a wrestler and probably better known for being in the movie The Princess Bride. Arguably, he probably started to get excess of growth hormone because he was still tall before epiphyseal plates closed, but it stayed very, very high. Notice the broad features in the face. On the right image, and I feel bad because I forget his name, kind of another wrestler, I believe, from a long time ago, his facial features were actually the inspiration for the character Shrek in the movie Shrek. But you can, again, see the kind of broad facial features, broad hand in the middle. So again, we already said it. We see enlarged hands and feet, broader facial features, protrusion of the lower jaw, thickened, oily skin, excessive sweating and body odor, little what's known as skin tags. And people often get this naturally when they're older anyways, but there's these little skin outgrowths. With acromegalia, you get more of them and you get them younger. Fatigue and muscle weakness, again, a deep, husky voice due to enlarged vocal cords and sinuses. Once again, if you've ever seen the movie The Princess Bride and heard Andre the Giant talk, he had a very deep voice. Also can have snoring interruptions to sleep, impaired vision, headaches, lots of bad things going on here. And of course, no big shock, as we talk about these endocrine disorders, we're going to see a lot of bad things. All right. Even more. Now, you can read all this. I'm giving you I'm giving you this PowerPoint so you can go through it. But one common thing with these hormones, even those that you don't typically think is directly related to reproduction, we're going to see often, it seems like, irregularities with some of these main hormones are going to have some changes to the reproductive system. So we can see here menstrual cycle irregularities in women, erectile dysfunction in men, and reduced sex drive. Notice also growth hormone doesn't just affect the hands and the face, but it's actually enlarged liver, heart, kidneys, spleen, big barrel-chested, enlarged tongue. But it's actually, let's focus here. This is actually what's going to cause a problem in the long run, because they start to get disproportionately large. And this is why these people tend not to live that old, as they end up having especially some heart problems. Now, what if we have the other extreme? What if we have hyposecretion of growth hormone? Once again, you probably could guess it. You could have dwarfism, which is growth hormone deficiency. It could be lots of different reasons for this. It could be due to a genetic mutation or an injury. But sometimes we just don't know. We can't tell why a person has this deficiency. Now, specifically with dwarfism, though, you'll notice that they have actually an average sized trunk. The difference is actually in the extremities, in the arms and the legs, with particularly short upper arms and upper legs, along with short fingers. So normal sized trunk, head, so forth, but the arms and legs are small. In fact, because of that, they look like they have a disproportionately large head with a prominent forehead and a little bit of a flattened bridge of the nose. What we'll also see, if you kind of remember the terms varus and valgus, when we talked about the skeletal system, valgus is when you tend to have the knees kind of concave in and the toes turn out a little bit and you walk pigeon-toed. This is or duck-footed, excuse me. The other way is more bow-legged. That's what's known as varus or gymnum varum. So they tend to be bow-legged, so the knees kind of tend to go out. Also, they tend to have an excessive lordosis, so they have a excessive lordotic curve in the lumbar vertebrae. All right, and typically about 4 feet tall. All right, so we just saw briefly hypo and hyper growth hormone. Now let's talk about the thyroid. We know if there's one word you want to think about thyroid, it's all about metabolism, right? And we also know, like growth hormone, affects basically every tissue of the body, right? I said almost. And what's it going to do? Because it's all about metabolism, it's going to increase oxygen consumption and energy consumption. It's going to increase heart rate. It's going to increase blood pressure. It's going to increase sympathetic stimulation. It's going to stimulate red blood cell formation so we can get more oxygen carrying capacity. And it's even going to stimulate other endocrine tissues. Now, we also know that T3 and T4 thyroid hormone is controlled by what? TSH, thyroid stimulating hormone in the anterior pituitary. Now, that's controlled by thyroid releasing hormone. Now, if we're talking about hyper versus hypothyroidism, you now have 3 areas where you might have a problem. Because if the hypothalamus has a problem as far as regulating TRH properly, well, okay, that could ultimately, we're going to have variation in T3 and T4. Same thing, if there's a problem in the anterior pituitary, not regulating TSH properly, again, we're not going to have the right amount of T3, T4. And if the problem is in the thyroid itself, again, obviously, we're not going to be producing the right amount of T3 and T4. Hopefully you can start to guess what's going to happen if you start producing too little or too much. An example of too much would be Graves' disease. And what's happening here is a little bit different though. You have thyrotropin receptor antibody, which is basically, it's an antibody, you know what that is. It's a protein that's going to help you fight off pathogens, part of your immune system. But what's going to happen is this protein can actually kind of mimic the action of TRH in the anterior pituitary. So basically, it acts like TRH, and all of a sudden, we're going to get abnormal regulation of the thyroid and this overproduction of thyroid hormone. So it's going to give us hyperthyroidism. Now, what we see here, if you are a fan of any a little bit older movies from the 60s or 70s, the actor on the left, you may have recognized him if you've ever seen Young Frankenstein. He played Igor. Very famous comedian, Marty Feldman. And he had Graves' disease. And one of the things is that you have what's known as Graves' ophthalmopathy, meaning that your eyes look like they're about to bug out. It's actually, there's a lot of pressure behind the eyes. And it has to do with, once again, too much thyroid hormone. Well, let's pause for a second. What would you expect a person with too much thyroid hormone stimulation to be like? Well, they will be very high metabolism. They're going to run warm, high heart rate. They're going to be skinny probably and wanting to eat all the time, nervous, shaky. And if you have this overproduction of thyroid stimulating hormone because of this antibody mimicking thyroid regulating hormone, it's going to get this pumping out action to the thyroid, you might also get a goiter, which is that's just this massive hypertrophy of the thyroid gland, because it's just trying to work so hard because it keeps on getting the signal, make more thyroid hormone. So let's see. What are some of the very specific features? I named a couple, but let's look at some of the ones on the list here. We have anxiety, irritability, difficulty sleeping. Again, I already mentioned rapid heartbeat, little tremors. They're going to run warm. They're going to have, kind of sweaty hands. And again, weight loss, even though they have normal eating, because they're literally running hot all the time. Again, notice that that whenever we have a problem with the endocrine organ, we often have problems sexually. So again, change in menstrual cycles, and again, in women that is, and again, erectile dysfunction in men. Frequent bowel movements and diarrhea. Why? Because everything's moving faster. We aren't even taking the time to digest things because it's even moving fast through the GI tract. Again, those bulging eyes that I mentioned before. Thick red skin on the shins and the tops of their feet. What's going on? You're actually turning over skin cells even quicker. And they're running hot. They're already going to be sensitive to heat. Now, there's another disease called Hashimoto's disease, or chronic lymphatic thridosis. Now, this is hypo, so this is low thyroid, right? In the U.S. It's the most common cause. And while it can occur to anyone, it's most common in middle-aged women. And what's happening here is that the immune system, so now we have another immune system, autoimmune issue here, mistakenly attacks and starts to destroy the thyroid gland. And hence, it can't produce as much hormone. So now, if your immune system is actually attacking your thyroid, we cannot make enough T3, T4. And at first, there's no obvious signs. It starts off really slow, and often subtle. And if you think about what would hypothyroidism look like, well, they'd be, as far as just fatigue, they'd be slower, they'd be depressed. It's the opposite before with hyperthyroidism. When food goes through you fast, you have diarrhea. Here you have constipation. You have some weight gain, dry skin, puffy face. Again, what do we have? Irregular menstruation. So again, problems with reproduction. Intolerance to cold. Why? Because you have a hard time keeping warm. You have a hard time keeping up your metabolism. And again, we have the potential for a goiter. Why is that? Well, as far as the thyroid goes, the goiter might be because we're trying to make too much thyroid, so it's actually reproducing. And other times, the issue is we're not making enough, but the cells themselves get large. So if you remember, the thyroid, it's a follicle. The thyroid gland has a whole bunch of these follicles, which are these cells. They're actually be cuboidal cells, but I'm drawing more squamous here. They look like this. Well, sometimes you actually have an increase of the colloid in the middle, so the individual follicles get better because we actually are making thyroid, but we aren't getting it out. In other cases, the actual cells get bigger. And on either case, whether it's the cells get bigger or the colloid in the middle gets bigger, the net effect is this goiter. All right, going a little quick, stick with me here. Now we're going to talk about the adrenals, specifically the glucocorticoids. So we know those are the ones that are going to have to be in the adrenal cortex. It's in the name there. Right there. And we know, of course, the glucocorticoids, these are the ones going to be helping regulate glucose. And these are especially for stress, so this would be like cortisol. So if we have overproduction of the glucocorticoids, such as cortisol, what's that going to do? Cortisol breaks down tissue to help raise blood sugar levels, which means we're going to have excessive breakdown of protein, which is something like breaking down muscle, to actually help maintain glucose metabolism. Underproduction of glucocorticoids means we can't, well, this is your stress. Remember, this is part of how you deal with stress. We won't be able to tolerate stress. We won't be able to mobilize those energy reserves and maintain blood glucose concentration. So let's give a couple examples. So you have Cushing's syndrome. Now, in this case, we have too much. So we have hypersecretion, excess levels of the hormone cortisol. And you see this weight gain and these fatty tissue deposits, especially in the midsection, upper back, and the face. You get this moon face, and also between the shoulders. Well, why is this? Because we're actually breaking down proteins, and so we're releasing it into the bloodstream, and we're breaking it down so we can make glucose. But then we're increasing glucose in the bloodstream. Where's it going to go? It's not going to go back to muscles. It's going to go to your lipids in your adipose tissue. Go back to your lipid reserves. You get these big purple stretch marks on the abdomen, thighs, and breasts, thinning, fragile skin that tends to bruise easily, slow healing of cuts. Well, why is this? Because cortisol is important for reacting to stress, and that's what's happening here. It's part of this process. Again, we see loss of emotional control, anxiety, depression. Why? Again, this is part of your stress response. It's not working properly. In fact, you can even have cognitive difficulties as well. Problems with high blood pressure, glucose intolerance may lead to diabetes. Why? Again, because we're dumping glucose in the bloodstream. Headache, bone loss, and what have you. Again, I'm not expecting you to memorize all these little bullet points. I'm expecting you to understand them. Understand the big ticket items. So if you have an overproduction or an underproduction of cortisol, what would you expect to happen? And in this case, it's a hypersecretion of cortisol. Now, specifically, women with Cushing syndrome, guess what? They're going to have, I'm skipping to the bottom one again, irregular or absent menstrual periods. Sound familiar? But it's also going to create thicker, more visible body hair and facial hair. In men, guess what again? Decreased libido, decreased fertility, and again, erectile dysfunction. Are we seeing a bit of a trend here? So that's Cushing's. Now let's talk about Addison's disease. And actually, President Kennedy was actually a person who had Addison's disease. This case, the adrenal glands themselves are damaged, which means we have hyposecretion of cortisol and even aldosterone. Remember, that's the other one in the adrenal cortex. The adrenal cortex has 3 layers. And I said as far as the hormones, it's salt, sugar, and sex. Sugar, salt, excuse me. Well, here's the salt, right? This was the one that's going to help control salt levels, sodium levels in the blood, as well as potassium in a sense. And it's going to also regulate blood volume. Cortisol is all going to be about sugar. So what's going to happen with Addison's disease? Again, muscle weakness, fatigue, weight loss, decreased appetite. You get this darkening, this hyperpigmentation of the skin, lower blood pressure, even fainting. Well, that might happen for a couple reasons. We're not regulating blood sugar well, but we're also not regulating blood pressure well. You get this salt craving. Again, that would be because of aldosterone. Low blood sugar, that would be because of the cortisol. Again, you can see some of the other ones here. No big shock again. What do we see? Sexual dysfunction in women. Endocrine issues are not fun for your sex life. All right? Now, I do want to pause, though, for what's known as an acute adrenal failure or Addisonian crisis, because this is a big deal. This is life-threatening right here. You start with pain in the low back, abdomen, legs. All of a sudden, you get this severe vomiting, leading to dehydration, low blood pressure, and loss of consciousness. What's happening is you have hyperkalemia, this high potassium levels, because we're not regulating it with aldosterone appropriately. Probably aren't, once again, we're not also regulating blood sugar as well very well. This is a trip to the ER. This can be big time trouble when you throw off your electrolytes with this bad. Because all of a sudden, you know that if we're not regulating our sodium and potassium well, what's dependent on regulating sodium and potassium well? Oh, things like neurons, muscle cells, including cardiac muscle cells. So we need to be able to regulate our ions in our plasma. All right, insulin. We already covered it before. I know it's a bit repetitive, but let's talk about diabetes mellitus. So in type 1, once again, what used to be known as the diabetes that you, in a sense, you tend to be born with, and what's going on here is another autoimmune issue with the immune system actually attacking the beta cells of the pancreas. So what's going to happen? It's not going to produce insulin, or at least very little to no insulin. So instead of being able to be transported into the cells, the sugar remains in the bloodstream, in the plasma. So remember, that means we have energy in the blood, but it can't get into the cells. So there's a genetic component to this, environmental factors, there's lots of different things that can go with this, but this is, of course, the insulin dependent. You take insulin since your body can't make it. Type 2, on the other hand, again, well, that's the one that's usually environmental. So in pre-diabetes first, before we actually get to diabetes type 2, you become the cells become resistant. It's a big difference here. Type 1, you can't make insulin. Type 2, you make an insulin, but the cells are becoming resistant to its effects, so we end up still having the same problem, that we cannot move sugar into the cells. So again, same thing as before, sugar builds up in the bloodstream. So the cells, again, are starving for food, but just is not able to get in efficiently, at least. Being overweight, again, is incredibly linked to the development of type 2 diabetes, but not everyone with type 2 is overweight. So there's a connection. And again, this is why where we used to call type 2 adult onset, we just call it type 2 now, because we now have kids, sadly, with type 2. What can happen? Mentioned before, it's a much greater chance for heart attack. And because we're basically getting abnormal blood flow, it's going to affect the eyes, possibly build up of cataracts or diabetic retinopathy. Like I said, basically, if you look at the image on the right over there, what's going on there? There's just like excess blood vessels. The cells are starving, so your cardiovascular system, in a sense, the blood vessels are trying to go out to these cells to deliver more blood, but it doesn't matter because it can't get in the cells. And then all of a sudden, you start getting blood vessels that start bursting in there. In addition, it can, because of lack of blood flow properly to the extremities with all these problems, and again, the energy can't get in the cells start to die. And that can lead to ulcers, such as in your feet, foot ulcers. And you can imagine if you've got big old holes in your feet like that, that means we've broken the skin barrier, so you're open to infection. And if it gets bad enough, it can in fact lead to diabetic amputation of the lower extremities. So again, we kind of went over these previously, but there's lots of big problems with diabetes, cardiovascular disease, again, nerve damage, kidney damage, eye damage, foot damage, skin and mouth conditions, brain problems, and cancer. Now, one particular group of people that need to be a bit concerned about diabetes is actually pregnant women, what's known as gestational diabetes. And when a woman gets gestational diabetes, it tends to be temporary for her, but the babies tend to come out a bit larger, and it's also somewhat dangerous for her. So what's happening here is, again, we have excess sugar in mom's blood, which is now going to go to the baby. So now we're going to have excess growth. So the babies come out pretty large. It's also going to trigger the baby's pancreas to make insulin, which actually can grow, once again, cause the baby to grow too large. I've already said that. In a sense, the crazy thing is you end up with hypoglycemia, potentially in the long run, because we're not actually regulating this properly. That's with the baby, of course. And you also have problems with what's known as respiratory distress syndrome, jaundice, and type 2 diabetes later in life. This is all talking about the baby. All right, and potentially even death. That's a bit of an extreme for the infant. All right, we talked about some potentially horrid problems that can arise due to basically endocrine pathologies. All right, please review that area in your book. And for me right now, what I want you to start to really think about is how it's logical. If you know what the hormone does, it makes sense if it is made too much or if it's made too little. You should be able to see how it throws us out of homeostasis and should almost be able to predict, not almost, you should be able to predict what the symptoms would be. All right, see you next time.